Today's topic is CPT Anesthesia Services. In the surgery integrated system, we have seen, these procedures, some of them are minor, some of them are major procedures, right? Major in the sense extensive procedures. So they are very painful procedures, whether it is, small incision or like IND or major grafting procedures or ectomy procedures. They're all highly painful procedures. So patient has to be given anesthesia before starting the surgery. This is very important, right? So, to provide anesthesia services, we have anesthesiologist and a couple of other providers also. So today we'll look at these anesthesia services in your CPT. And as you can see here, the anesthesia service codes in CPT, they are from within the range of 001002 So all these codes they'll be updated along with the CPT codes every year, and based on the recommendations from American Society of Anesthesiologists (ASA), what you call. Okay. So what is anesthesia basically? So it's an induction or administration of a drug to get partial or complete loss of sensation. That's very important, right? So surgery should not be painful. That is the motto and the objective of the healthcare. And of course, we have another term called analgesia, absence of pain. Um, and like I said, anesthesia services are provided by anesthesiologist who is an MD physician, and we have anesthesia assistant and CRNA, certified registered nurse assistant. So they can also provide anesthesia services. The difference is all of them are licensed. The difference is anesthesiologist is an MD, whereas CRNA is nurse practitioner, anesthesia assistant, allied professionals. So, anesthesia assistant or CRNA, they can provide anesthesia service independently for minor procedures. Um, Also, they can provide anesthesia services under the supervision of anesthesiologist, because anesthesiologist is the boss. So, anesthesia assistant, CRNA, they work under anesthesiologist directly or indirectly, right? So this is the important. So here you can see typical anesthesia service form. So that is documented by anesthesiologist. You can see here patient identifiers, name, date of service, the facility, hospital name, what type of surgery is it? Is it outpatient surgery or inpatient? Who is the surgeon? Anesthesiologist himself, anesthesiologist name, and MD is anesthesiologist. Then pre-op and post-op diagnosis procedure. What surgery is done? Very important. Anesthesia type, is it general or spinal? We'll discuss. And start time, stop time. Anesthesia start time, stop time. Very important. And ASA physical status. So we'll discuss what is physical status. Then apart from general anesthesia, are there any services rendered? So there is also documented. And finally, signature. Right. So these are the documentation elements must be documented by anesthesiologist. So based on this information, the coders, they're going to do abstraction and assign codes. And of course, you have to look at some other documentation also. We'll see. All right. So before we proceed to the codes, let's see what are the types of anesthesia. So general anesthesia, spinal anesthesia, regional anesthesia, MAC, monitored anesthesia care, and there is moderate conscious sedation. These are the different types of anesthesia service. All right. Uh, it will be clearly written by the anesthesiologist what type of anesthesia is given. There is local anesthesia also, but I did not include here. The reason is, if a procedure is done under local anesthesia, local anesthesia will be given by surgeon himself or herself. You don't need anesthesiologist for local anesthesia. Local anesthesia is part of the global package, global surgical package. So that's the reason I didn't include local anesthesia here. For only these type of anesthesias, your anesthesiologist is required. Then routes of administration. What do you mean by routes of administration? The drug. We see basically it's all about the drug, right? The drug that will work and provide painless condition to the patient. How the drug will be administered? If it is general anesthesia, it's a gas. Then intravenous administration also. Endotracheal means inhalation. Patient will take inhalation. Then intravenous through IV. If it is regional, there are a couple of things like field block, nerve block. So they give injection directly to the nerve. Regional means only one hand is paralyzed or one leg. Remaining body, patient will be able to feel the pain sensation, but only where the surgery is done. For example, surgery is done on the leg. So through regional block or anesthesia, you can make only the leg pain in a painless condition. Spinal anesthesia. So if you give spinal anesthesia, entire lower portion of the body that will be painless, including abdomen, epidural, of course, similar to this. So these are the routes of anesthesia administration.
Sir,
Yes, yes, please.
what is the difference between local and regional one? Because in the local anesthesia also we are uh, temporarily we'll put the anesthesia for that particular organ.
Right. So local anesthesia is confined to only the superficial area of the, including skin, subcutaneous tissue, up to that level only. So, for example, if you're working on a muscle or deeper tissues, so local anesthesia doesn't work. So local anesthesia is only, it covers only limited area, like around 10 centimeters diameter, um, and maybe up to the subcutaneous tissue level. But beyond that, the local doesn't work. So, for example, if you are working on a bone, leg, for example, there are two patients. One patient is with the skin problem, another patient with bone problem, and so local anesthesia will work if you're working on a skin problem. But the bone, yeah, local anesthesia doesn't work. So you have to go for regional anesthesia or something of that kind. And also depends upon the duration, the time duration. For if it's a minor procedure, you do it in a 5 to 10 minutes max, right? Local anesthesia is fine. But even if it is skin, if you're working for 30 minutes for a graft procedures, 40 minutes, no, local anesthesia is not suitable because local anesthesia work only 5 to 10 minutes, and every time you have to keep on giving local anesthesia. But regional anesthesia, if you give, if you anesthetize one particular nerve, yeah, it will be there for considerable good time, 30 minutes, 1 hour.
And sir, what you said, like one thing, like the local anesthesia is given by any physician, but these are from MD and all. This
Yes,
is also
yes,
the difference.
yes. Because local anesthesia can be surgeon, is capable of doing local anesthesia because it's a minor, but regional, general, it requires certain amount of time, care for the patient. Yeah, that is the reason the anesthesia is required. All right. For example, yesterday we have seen I&D, skin repairs, simple repairs, intermediate repairs. You do it under local anesthesia, obviously. But for procedure like the extensive grafts or breast procedure like mastectomy, yeah, I mean you cannot do under local anesthesia. All right. Okay, now we know what is anesthesia service, who is licensed to provide anesthesia services, what are the types of anesthesia, um, and now let us look at the anesthesia service package. So if anesthetist has to receive full payment for the anesthesia particular service code when you bill, what services should be provided? Pre-operative evaluation. So before surgery, the anesthetist has to examine the patient, take the history, examine the patient, and give the fitness certificate. Okay, patient is eligible for receiving anesthesia. That is important. If anesthetist doesn't provide fitness, the surgeon cannot do surgery. That's important. That is pre-operative evaluation, and of course, the post-operative anesthesia recovery care and intraoperative care. So during surgery, anesthesia has to be provided. Maybe 30 minutes, 1 hour, 5 hours, 6 hours, depends. And after the surgery is over, when the patient recovers from anesthesia, until that time, the anesthetist has to anesthesiologist is responsible. That's the meaning. Yes. So responsibility starts with the preoperative evaluation to post-operative anesthesia recovery care. But major work is during surgery, intraoperative care. Yeah.
Sir, general in what will be the general requirements we need it before anesthesia if we are giving, for example, like if any patient is coming in the ER for any and suddenly they move to the surgery, like some accident happened or something happened, then and because of the surgery they have to give the anesthesia. So that time how they will evaluate that person is completely fit for the anesthesia, because we have to go for the surgery that time.
Right. That's a good question. You're right. Yeah. See, I mean, depends upon the nature of the surgical problem, and also, yeah, in the sense whether the surgery has to be done immediately or it can be done electively. Yeah, actually, elective in the sense when the patient is all right, when the patient is fit, that's the time we can do the surgery. That is elective surgery. But like you said, if it's an emergency surgery, so there is no time, it has to be done. Patient has to be rushed to OR, and anesthesiologist, whether the patient is fit or not fit, it doesn't matter. He has to proceed with anesthesia. So when I said um, fitness, that is in case of elective cases. But like you said rightly, I mean yes. So if it is an emergency surgery, the patient has to be taken up for surgery. An anesthesiologist has to be ready to provide. Of course, there is a risk, right? I mean, for every surgery, every anesthesia service, there is a risk. There is risk due to anesthesia also. So that risk will be explained to the patient or patient attendants that it's an emergency surgery. Uh, for example, patient is hypertensive, there is diabetes, Before taking up surgery, you have to take care, and hypertension is under control, sugar level is under control, all that, right? But now it is an emergency surgery, you have to carry out. So you explain that risk to the patient and proceed. That's right. All right. So intraoperative care during the surgery, anesthesiologist has to do a lot of things, in the theater. So sometimes, it's a single anesthesiologist. He will run from here and here, from here to there. That's how it goes. Um, Anesthesiologist has prepare the patient, um, start the IV line. He has to put the airway, nasogastric tube, um, administer all of injections. If it is required, blood transfusion, take the ECG, EKG, and if patient is on ventilation, manage ventilation. If it's required, the CPR, take the blood samples. These are the routine works. These are all included in your anesthesia CPT code. So what I'm trying to say, anesthesiologists cannot claim separate payment for these services. For example, CPR is done. CPR, we have a separate code. What is CPR? CPR.
Yeah, the
Yeah, it is. Yeah,
cardiopulmonary
yes. Cardiopulmonary resuscitation.
resuscitation.
So when patient is respiration or heartbeat, yes, that's the time you put artificial respiration, and so we have separate CPT code for the CPR, but anesthesiologists cannot claim separate payment for CPR. Similarly, ventilation management, all this, because it's a package. They're all part of each um, anesthesia code. If you are submitting 00100, the anesthetist has to do all these things. Then only we get paid. But what is not included in the package and what can be billed separately, these are the five services. Arterial line. IV line is routine, but arterial line is not routine. If the anesthesiologist is putting catheter in the artery, you can bill it separately. There is a separate code. Similarly, Swan Grange catheter. Don't worry about this terminology. These are different lines. Central venous line. So, of course, we're going to discuss all this, what it is in the next sections, not in this section. But for now, you just remember the arterial line, Swan-Ganz catheter, central venous line, and nerve block for post-operative pain relief. Sometimes what happens, surgery is over, anesthesia is over, patients complain severe pain. What do you do? So they'll give some injection, painkiller, but that is not sufficient. So at the time, anesthesiologist has to proceed with nerve block or epidural catheter for post-operative pain relief. These nerve block epidural catheter, they can be built separately. You can build them. So you have to remember these five services. You're not going to miss them. Right? We are discussing the anesthesia billing concepts or coding concepts. Then anesthesia time. When anesthesia time begins and ends, that's very important. So this is the definition of the book. It's a CPC typical question. Anesthesia time begins when the anesthesiologist begins to prepare the patient for the induction of anesthesia in the operating room. So the moment the anesthesiologist starts preparing, then ends when the anesthesiologist is no longer in personal attendance. That is when the patient may be safely placed under post-operative supervision. So what happens, after the surgery? So patient will be shifted to post-operative ward. Anesthetist has to go to the post-operative ward and address the patient. Hi, how are you? Are you okay? The patient has to answer. That's when this anesthesiologist will leave. That's the time, anesthesia time ends. So you have to remember these. Of course, it's the open book method in the examination or your coding at the time of the hospital. Um, so you have to remember the central meaning of this concept. But for book use definition, yes, you can always refer to the book. So where do you get all these guidelines? Let's go to the CPT, um, anesthesia. So this is your anesthesia guidelines from here. So we are taking the points, all these points from this page. What is included in the anesthesia services? This is a paragraph. Anesthesia time. So you have to go through these pages without missing, right?
Sir, what is the page number?
This is 64. I mean, PDF page is 98.
Okay.
So for all the sections, the guidelines page is important. All right. Yes, your codes within the range of 001 002 01999 modifiers again. So modifiers, the first, yesterday we discussed modifiers related to surgery. So this is list of modifiers 23, unusual anesthesia. But I hope by this time you are able to understand and talk about this particular modifier 23. Anybody you want to add something here? What is 23 modifier? When do you assign 23? So, for example, appendectomy, surgery, routine surgery. Typically, how much time it will take for anesthesia for appendectomy surgery? Maybe 30 minutes, 45 minutes. Yeah, there is a typical time. But sometimes, one in thousand patients or one in 10,000. So what happens? The time extends to maybe 2 hours. In rare cases, it is possible, right? And anesthesiologist has to support for the 2 hour surgery. That's when you assign 23 to your anesthesia code. This 23 is not for surgery course. It's only for anesthesia course. All right. So we have other modifiers, what you call physical status modifiers. Anesthesia physical status modifiers. So let us take every time. So this is the anesthesia service. You code it. Your code is 00100. And patients are, you have different patients based on their health condition, right? So if a patient is healthy, that is P1. So you're going to sound like this. If the patient has mild systemic disease, what is mild systemic disease? Like hypertension, diabetes, asthma. Those are all systemic diseases. Mild. Mild means patient is able to manage. whereas P3 is severe systemic disease, not under control. Sugar level is 600, but you have to do the surgery. Blood pressure is 180 by 110, very high, but you have to give anesthesia. That is P3. Emergency surgery because you're not looking for some time to control the blood pressure. So P3. P4. A patient with severe systemic disease that is constant threat to life. Patient has diabetes, asthma, or it could be any chronic condition, totally uncontrolled. That is P4. P5. A moribund patient who is not expected to survive without the operation. So it's an emergency condition. Maybe road traffic accident, head injury, chest injury, internal bleeding. Like you said, patient has to be taken directly to the OR. Yes, it is P5. So what happens when you put P5 and submit the bill? 00100. Imagine this is $10,000. When you add P5, automatically 20% of fees will be applied. The payment goes up. So that is the purpose of these. These codes not only indicate patient status but also they affect the payment reimbursement. P6, a declared brain dead patient whose organs are being removed for donor purposes. That is P6. So I hope
So
you.
why we need why we need P6 uh, to a brain dead person also we are going to give the anesthesia?
Yeah, actually, in the sense, anesthesia. See, anesthetist is a licensed physician. Um, Here, anesthesiologist service. We are talking about anesthesia service. Anesthesiologist service may not be just to reduce the pain, but also to manage the patient. The patient is brain dead. Of course, patient is not feeling pain. Yeah, you're right, but he has to be managed. The internal blood circulation, the respiration, because definitely he's in the ICU. His vital force has to be managed. So usually intensivist, who is anesthesiologist, he will manage these brain dead patients. So by giving IV fluids, whatever, any service provided by anesthesiologist.
Mhm, mhm. And sir, how to differentiate between P3 or P4? Because P3 is also severe systematic disease, and
Mhm.
P4 also is the same, but it is threat to the life. So when it has these kind of symptoms, severe symptoms, the P3 patient also will have a constant, threat to the life.
Correct. Yeah.
So how to distinguish, like, whether we have to put P3 or P4 if a patient is with the severe.
Hmm. Yeah. So usually it is anesthesiologist that will indicate ASA physical status. Two means P2. So anesthesiologist will decide. So you will just take the information from anesthesiologist notes. But in case if you think that anesthesiologist is wrong, yes, you can advise the anesthesiologist. If he accepts, yes, you can assign P3 or P4. But to give you a general idea, quick idea, the difference between P3 and P4, in fact, P2, P3, P4. Again, diabetic patient, systemic disease, blood sugar, there's a parameter that is checked as the anesthesiologist. If it is 130, blood sugar is 130 milligrams per deciliter, that is normal. That is mild, under control. Random blood sugar we're talking about. Even if it is 150 is also fine, P2. But if it is 250 or 300, that is P3. If it is 600, that is P4. A quick idea, guys. Similarly, hypertension, blood pressure. Patient is known hypertensive on medication. Blood pressure is 130 by 90, that is P2. But 170 by 100, that is P3. 220 by 120, that is P4. That's how it is. But like I said, yes, it is the anesthesiologist that will decide.
Okay, sir.
Sir,
Yes.
um, I have a scenario like a new patient comes and we decided that whatever issue he came with, and next day we are going for the surgery. And before the surgery, next day we give the anesthesia. So we are going to put the anesthesia code, surgery code, and if the patient is coming with hypertension, but that time his blood pressure is normal, so we will just put the P2 modify.
Oh, yes. I mean, see, basically, what you do as a coder, what we do, we code the charts when the service is totally completed. When the record is closed, that's when we start coding. So, what do you mean by record is closed? You have records. You have two types of records. There's these records: open records, closed records. Open record means still this is under documentation process. Still, it's not documentation is not completed. That is open record. So once all these fields are completed, when the anesthesiologist puts a signature, then that is called closed record. So that's when these records will reach you. So that means service is already done and the documentation is also already done. So you have for coders, complete documentation is very important. So what I'm trying to say, by the time this record comes to you, the service is done, documentation is completed. Now you have every information. Yes, that's when. So yes, you have to give the diagnosis codes on one side. Plus, if you are coding for anesthesia service, yes, you have to give only codes for anesthesia services from zero series, along with modifiers. Yes, I mean, is that what you're expecting? I mean, did I get your question correctly, or did I miss something?
Yes, sir. Yes, sir. My question was just like if in the exam the normal scenario comes like as I gave it to you. So my question was like we have to write the anesthesia code and then surgery code and the modifier. That's it.
Yes, yes, absolutely. Because
Okay.
surgery code, sometimes what happens, um, the surgery codes are totally, that's a totally different department. You have surgery codes also. They'll apply surgery codes. You don't need to apply surgery codes. Um, but your anesthesia codes depend upon surgery codes. In some cases, in some facilities, if it is a small center, yes, one coder has to apply codes for surgery, at the same time apply codes for anesthesia service also. Yes, that's also possible. But when you are dealing with this topic, please remember your focus is on anesthesia codes, not on surgery codes.
Okay.
So, sir, let's first finish the theory part. Otherwise, we are getting distracted. So
No problem.
then
That's okay.
we have to park the question at the end, please. Yes,
Okay.
sir.
Okay. All right. So this is we have qualifying circumstances also, add-on codes. We know what is an add-on code. In anesthesia also we have add-on code. First one is 99100. Can anybody read please what is 99100?
Anesthesia for patient of extreme age, younger than 1 year and older than 70.
Yes.
For procedure performed on infants younger than 1 year of age at time of surgery. C 00326, 00561,
Mhm.
00834, 00836.
Yeah, I mean, okay, that's fine. Let us make it shorter. Yes. So this is 99100. If a patient is less than 1 year or more than 70 years age, and anesthesiologist is providing service, we have to give this additional code. Um, what does it indicate? It indicates complexity because providing anesthesia for young patients less than 1 year or elderly patients more than 70, it is a bit complicated. So when you apply this code, you will get additional payment. This code not only provides information about patient age but also affects the payment. Similarly, we have 99116, complicated ventilation of total body hypothermia. Sometimes some surgeries, body temperature has to be lowered. That is the responsibility of the anesthesiologist. There are certain drugs, mechanism through which body's temperature will be decreased. Complex procedure. That is 99116. 99135, complicated ventilation of controlled hypotension. That means during surgery, blood pressure has to be decreased for a reason. So honestly, we'll give some drug, the BP will fall 80 by 60. Yes, the anesthesia will get additional payment. Then 99140, anesthesia complicated emergency condition. Emergency, there's no time. Then 9, everybody has to rush, right? So no matter what kind of emergency is it, but patient's condition is an emergency. That is emergency. 99140. So all these circumstances, will be documented by anesthesiologist. Based on that only, you can assign this course, add-on course, qualifying circumstance. You have all these. Where do you find? Yes, and there's guidelines, anesthesia guidelines. Here your physical status modifiers and your qualifying circumstances. All this.
So supplied materials is also written. What is this in this book?
Yes, apply materials they have in this here.
Yeah, in this page. Supplied materials.
They basically it doesn't it's not applicable for because anesthesiologist is responsible to provide the professional service. So the supplies, all these things will be provided by the facility. So drugs, supplies, so everything will be provided by the facility. But anesthesiologist, of course, there is given one code 990. Can you quickly check what is 99070? So this is for the facility, not for professional coding. Because anesthesiologist, yeah,
Supplied material, does it come under HICPICS?
no, there's a code given 99070. Yeah, of course, obviously the hip fix, but I'm just referring to this code 99070. So what I'm trying to say, materials is the responsibility is facility hospital, but we are coding here for the professional service for the anesthesiologist. Okay, you can ignore that. That's fine. All right. So before going proceeding to another set of modifiers, let us look at the codes. how we are going to apply the codes. Let us quickly review how the codes are organized. Head, neck, thorax, head to toe, right? Started with head and ended with forearm, wrist, and hand. These are extremities, limbs. Of course, after that we have certain other procedures like obstetrics, burns. So, what do you mean by this arrangement? Please remember, the surgery is done on this body area. It is not the anesthesia. It is surgery is done in the head, surgery is done in the neck, surgery is done in the spine. These regions referring to the surgical site. Very important. Now, the first site, head. The surgery is done under in the head region. That's the meaning. But anesthesia, it could be general anesthesia, it could be regional anesthesia, whatever. So, anesthesia coding is it is not that difficult if you understand the this arrangement. These are all procedure names. Please remember, these are all procedure names. The surgical site and the procedure names. So, what are the organs you find in the head? The of course we have the skin, muscles, bones, skull bones. There is a brain, and of course eyes, ears, nose, mouth region. So surgery can be done in any one of these regions. But for which the anesthesiologist is providing anesthesia. Now I'll ask a quick question. Cataracts eye surgery is done. The patient is undergoing eye surgery. Anesthesiologist is giving anesthesia. So which service code you will report for the anesthesia service?
00148.
148. Yeah, you're very closer. So is there only single code or multiple codes for eye surgeries? For eye surgeries, the code starts from 001402 148. These are all codes for anesthesiologist, but surgery is different. So in this 142, cataract surgery is being done. 144 cornea, 145 vitreoretinal. So these are different surgeries. But if you don't know the surgery name, your code is 00140, not otherwise specified. It's a generic code 00140. Very good. Yeah.
So this is under which part of the body? The eye?
Under head, we have the heading head. Within the head,
Okay.
eyes, nose, mouth,
So
brain.
basically all the face
Yes,
uh, above the neck.
above and exactly right. Yes, you're right. For example, brain surgery is done. Patient is undergoing brain surgery. Anesthesia is provided, and you have to report your coding for anesthetist. Then, what are the codes applicable? 00210. Anesthesia for intracranial procedures. Intracranial means within the skull, like brain, whatever. So we have 00210 up to 222. These are all related to within the skull. It could be brain or other than brain. Similarly, for example, tonsillectomy is done under anesthesia. So, what is your anesthesia code? So, tonsillectomy is tonsils are in the mouth, right? If you look at 00170, anesthesia for intraoral procedures. Intraoral means within the mouth. It can be tongue, it can be tonsil, it can be adenoid, anything. So we have a generic code as well as specific codes for procedures. So cleft palate repair, we have a very specific code 00172. So to code anesthesia services, yes, one must have surgical knowledge also. One must know what is the procedure, what is the surgical procedure.
So will the procedure will be given in the documentation?
Yes. So like this, procedure name, cystoscopy, transurethral resection of prostate. So surgery is done on prostate gland through cystoscopy. Yes. So based on this document, you'll apply ICD course, diagnosis course, as well as you can give a code for surgery also, plus anesthesia code. And you have the procedures on neck region, surgeries on neck, then surgeries on thorax, means chest region, intrathoracic, like lungs, heart procedures, spinal cord, abdomen, upper abdomen, lower abdomen. What are the upper abdomen organs, lower abdomen organs? Upper abdomens, for example, liver, stomach, lower abdomen, appendix. So these are the different organs. Perineum, pelvis, and legs, upper leg, lower leg, upper arm, and forearm, wrist, hand. These are the surgeries where surgery is done. These are all X-ray, CT, MRI, for which sometimes anesthesia is required. Burns, burn treatment under anesthesia. Obstetric procedures, like deliveries, normal delivery, cesarean delivery, if done under anesthesia, yes, you have the course. So you have very limited number of codes in anesthesia, and all that you have to do is identify the surgical site where the surgery is done and which organ system and what procedure. Three questions you would answer: what is the surgical site, and what is the organ, what is the procedure. So let us examine one question, one example. Can you give me any simple procedure that you know that you want to examine now? Any procedure, simple procedure, or any procedure that you know. Surgery procedure.
So will the root canal also comes in the surgery?
Any procedure, I mean. So if the root canal is done under anesthesia, for example, anesthesiologist is involved, maybe GA is given, for example. Root canal, they can do it under local. If it is done under local, no, these codes will not come into picture. But if root canal is done under GA, imagine. GA. So services provided by anesthesiologist, and yes, can you give the code for anesthesiologist? The dentist will focus only on the teeth, but the anesthesiologist has to focus on the entire body of the patient, especially vitals, heart rate, blood pressure, respiratory rate, right? That's important.
So 00170 is for mouth. So
Yes, because that's the only way. Because intraoral procedures, anything 00 172, 176, but 172, 174, 176, these are specific procedures. Anything other than these three, you have to go with 00170. Yes. For example, let us take a different one, knee replacement surgery for a 70 years male patient. So this is the, now let us put it as 75 years. Now under anesthesia, under GA. Can you find code for anesthesiologist? Now you know where to go.
01320.
01320. Yeah, you're under the right heading. 132. And see for all procedures of nerves, muscles, tendons, fascia, bursa, knee, under popliteal areas. So I'll put it as knee joint replacement. I'll put it as knee joint replacement. Now you want to review your answer? This knee joint replacement.
1382.
1380.
13.
80.
Yeah. Anesthesia for all closed procedures on knee joint. So it's a closed procedure. But when you do giant replacement, it becomes open procedure.
And so 9910 100 also applicable here because patient is 70 years.
Yes, that's an add-on code. Yes, very good. But yes, what's your primary code from this series?
So, sir, that will be 70 or more than 70?
Was 70 or more, or what it is written there?
I, this was
Yeah. If it is more than 70, it should start from 71.
start from 71, sir, because
Okay.
it's older than 70.
Yeah. Here, 75 years old patient.
Okay. Yes.
All right. So for knee joint replacement, what's your primary anesthesia service code from this? So look at this code 01402.
Sir, what is the close and open? Can you please repeat one more time?
Yeah. Close means you are not putting knife. That is close. There are certain procedures. Sometimes anesthesia is required. Open means you're putting knife. You're opening the body side. That is open procedure. So I'll give an example. Knee joint dislocation. Patient is coming with knee joint dislocation. Only there is swelling, but externally there is nothing. There is no bleeding. Knee joint dislocation. How do you? What is the treatment for knee joint dislocation? So it's a you don't need surgery. You don't need to put knife. The orthopedician, what he will do, he will manipulate. He will manipulate and put it right, set it right. That is closed procedure. But doing manipulation when the see knee is already dislocated, it's a very painful condition. On top of it, the orthopedician has to manipulate, twist the knee joint to put it right, to set it right. It's unbearable pain. That's the reason what they do. They'll give anesthesia for this procedure. Patient is painless now. The orthopedician, you will proceed with the manipulation. That is closed procedure. Fractures, dislocations, closed treatments. So this is 01402 total knee arthroplasty means knee replacement surgery. So your answer for this 01402. Yeah, I mean, it's good that you're able to identify the body area you're coming closer. But as you discuss more and
Sir,
more, yes,
yeah, sir, the subhead, the heading is written there, knee and popliteal area. What is popliteal?
yes,
That's it.
this is anatomical areas. Popliteal area is behind the area behind the um, knee joint area, but behind the area behind the knee joint is popliteal area, backside portion of the knee. That is popliteal. All right. So this is a code for knee joint replacement. And of course, as I said, you'll give that add-on code also. Yes,
So, arthroplasty is joint replacement.
yes, arthroplasty. So, like I said, here you'll find a lot of surgery names here, surgery names, but you'll be able to code it. Don't worry, I mean, because we just started. Um, yes. So this is how you'll find codes. Now, just to summarize, let us summarize these steps. The first step is determine the surgical procedures performed and the corresponding anesthesia CPT code. When you read the operative report, the first step is you should know the surgery name. Otherwise, it is difficult. You cannot go to anesthesia code without knowing the surgery name. So that's the first step. You have to identify the surgery name. You have to identify the anesthesia code. Second step. Select the most comprehensive anesthesia code by determining which procedure has the highest dollar value. What does it mean? Sometimes, a patient will undergo two surgeries in the same time, especially children, myringotomy plus tonsillectomy. 7 years boy. Two surgeries done, right? Myringotomy is on which body area? When you say myringotomy, it is ear procedure. Tonsillectomy, it is in the mouth, oral procedure. Now, surgeon is doing both separate procedures, but anesthesia also you have two separate codes. Like you said, tonsillectomy, all oral procedures. What is the code? 00. Both are in the head region versus 00170. Myringotomy, ear procedure. Where is ear? Here it is. 00120. Anesthesia for procedures on external, middle, and in ear. 00120. So you have two separate anesthesia codes. So, for example, this is $500. This is $800. So, same surgery. And if you report these two codes, do you think the pair will pay separately 500 plus 800, $1,300? No, because the pair says, see, you started anesthesia and you ended. It is your response to end the anesthesia. Start time, stop time. So the surgeon, the anesthesia will get paid for the time also. You're allowed to code only one anesthesia code. So if you have a choice, which one you will report? Whichever has the higher dollar amount, that you will report. So it will report only 00170. That's how it goes basically. That's the meaning of the second step. Select the most comprehensive procedure code by determining which procedure has the highest dollar value if there are multiple procedures. Third step is assign physical status modifier, P1, P2. So in this case, um, 00170 P1 because 7 years boy, healthy patient otherwise, so P1. Determine the anesthesia time as indicated in the medical record. So your coder's responsibility is also fill in the time. For example, surgery started at anesthesia started 8 a.m. ended at 9 a.m. That is 60 minutes. So there's a field for minutes, 60 minutes, and every 15 minutes is 1 unit. So is equal to 4 units. So this is how we have to put 4 units. Then determine if additional procedures are performed that are separately billable. Arterial lines, Van Gange, CVP, post-operative pain management. So if it is done, you have to assign another code, otherwise leave it. 6. Add any appropriate qualifying circumstances like extreme age, emergent surgery. You have add-on codes, right? So you should give. So these are the steps.
So point number two, where we are telling that if there are two procedure, so let's say one is $500, other is $800, we are counting the 800 value because it is higher.
Yes.
So can you go to the slide, please, sir? Now coming back to the point number fifth, there is also additional procedures we are talking about. So second and fifth, isn't it the same one?
No,
Uh,
because yeah, this is here in the second we are talking about surgeries and anesthesia codes like zero series codes, zero series codes. So in this case, if you see, in this case you got your anesthesia codes from both from zero series. It's actually based on procedure surgery, but here this is additional service.
to another organ for another surgery of another organ type,
Or it's
another
not
organ system.
for a particular surgery, it is for the patient care. These are all additional services, need not be specifically for a particular organ, but to take care of the patient.
So for second point, we have to remember that if the code starts from the same digit like 001, it belongs to the same category. We have to take one with the highest value, correct?
Yeah, it's you don't need to. I mean, if they are both are from zero series, because all the anesthesia codes, if you look at the first character is zero. So if you have multiple codes from this section, you have to take only the highest one. But for this, you will get codes from surgery section. Arterial line, you will get from 30,000 series. This is again 30,000. This is 90,000 series. This is 30,000 series. This is 60,000 series. So codes for these procedures, they come from totally different sections. These are not from zero series. And these under second step, you have codes from zero series. Probably I will take a different example in tomorrow's class to explain. I mean, how we should take it forward from for the fifth point as well as second point. Yes, you need more examples, of course.
Uh,
Okay, thanks.
Sir,
Mhm.
like in the book, like it shows like radical surgery so many times. What does it mean?
Yes, radical. Yesterday also we came across radical. We did touch
Okay.
this point. Radical means usually done for cancer conditions. In cancers, they have to take out the entire organ. For example, cancer stomach, they will remove entire stomach. Plus, they remove part of the surrounding tissue also. That is radical.
Okay. Thank you.
So here we have an example here. Yeah. So transurethral resection of prostate is done under anesthesia. Now you have to find the anesthesia code. Can you find anesthesia code here?
So it's like 0092, the range
Yes,
starts from the.
00, because 0092. Yeah, these are all related to male genital system, male reproductive system. So if you see here 00914, transurethral resection of prostate, anesthesia for transurethral procedures, especially in transurethral resection of prostate. So your code is 00914, that is the code for anesthesia. Plus, if you see here, MD inserted arterial line in the left radial artery. So this is the additional service we are talking about.
Yeah, that is the exceptional, the arterial line, what you
Arterial line.
said.
For this arterial line, your code is 36620. Can you please go to your CPT code 36620?
Respiratory system.
36620.
Arterial catheterization or cannulation for sampling,
Yes,
monitoring, or transfusion.
because usually these catheters in the arterial vein, that is to provide drugs, to administer drugs. In this 00914, only IV line is included in this. If you are putting IV line, that is already included in this 0091. But putting arterial line, since that is not included here, you are billing separately. Yes. Now the anesthetist will get payment for 00914, maybe $5,000. Plus for 36620, you will get another maybe $500. So that's how the coding and billing will happen. Similarly, Um, what is not included? If the anesthetist puts swan gauge catheter, yes, there is a separate code for swan gauge catheter. Central venous line, there is separate CPT code. These also. In fact, this is an exercise for you homework. Now you know the code for arterial line. Similarly, you have to find codes for these procedures. Swan gauge catheter, central venous line, nerve block. Need not be accurate code, but at least you should give me a code closer to that particular section. Yeah, I mean, this is your homework. The slides are available. Yes, already. When you find these codes, just send me the codes in the group. Also. So these are all separately billable procedures. And so when we go here in your CPT, anesthesia. So these slides are over here. There is test 10 questions PC model. Then of course we have answers. Yeah, there's some additional questions also, around 20 plus.
Sir,
Yes.
along with P1, P2, P3, there is another double A code also in the example. Earlier also, I can see it here also. So what's that AA?
Yes. So these are the modifiers because so these are the modifiers. So we have time, right? Can we extend for another 5-10 minutes?
Yes, sir. I'm okay.
Okay. Well, let us finish it quickly. So these are the additional modifiers applicable for anesthesia codes. Like I said, MD anesthesiologist or CRNA, both are providers, but both are differently qualified. Right? If anesthesiologist MD is giving anesthesia, then you have to assign AA modifier. Now the payer will know anesthesia is given by anesthesiologist. So if CRN is given anesthesia, then you have two applicable modifiers, QX, QZ. What is QX? If CRNA is providing anesthesia under MD, under the direction of MD, then QX. But if CRNA is providing anesthesia independently, then QZ. So there are two modifiers applicable for CRNA. But for anesthesiologist, himself or herself providing AA, we have additional three modifiers also. What is it is? Like I said, anesthesiologist. Imagine there is a hospital. There are three operation rooms in a row. There are three operation theaters. One, two, three. Simultaneously, three surgeries are going on. Three surgeons they're operating. So what do they do? Anesthesiologists. We have only one anesthesiologist, but three CRNAs. Anesthesiologist, what he will do? He will just move from one room to another room, providing direction to CRNAs. Three CRNAs. If that is the case, QY, QK, AD. QY means medical direction of one CRNA. QK is medical direction of 2, 3, 4 CRNAs. AD is supervision more than 4 procedures. So these modifiers are meant for only anesthesiologists, whereas QX and QZ modifiers are for CRN. So go through these. Um, then we have another set of modifiers. QS, monitored anesthesia care. So in the beginning, if you remember, we have different types of anesthesia. One type of anesthesia is MAC, monitored anesthesia care, MAC. So if MAC is given, it is the same anesthesia course, but you have to give QS modified to these codes 00170 with QS modified Z8, Z9. QS, Z8, Z9, these are all MAC MAC, but the nature of surgery is a bit different. So there's deep complex surgery. Yeah,
What is monitor anesthesia classes?
yes, that's a type of anesthesia care. Um, like it's not like it's not as complex as GA. GA is highly complex. MAC is a procedure with the patient is able to patient is under sedation, but patient is able to respond to the stimulus. That is MAC. So don't worry about what is the technicalities. If MAC is, for example, this anesthesia report, anesthesia general. If it is MAC, he will write MAC, monitored anesthesia care. The moment you see monitored anesthesia care, you will use the same anesthesia code with the corresponding MAC course like G8, G8 or QS or J. So you don't find these modifiers in your CPT book. You'll find in PCS, HICPICS book. All this, a these modifiers as well as the Z9 you'll find in HICPICS because I already provided you HICPIC books. At the end, you can see these books, HICPICS. So yeah, I mean the today's discussion is about to be able to understand different categories of codes. So the technicalities, of course, yes, you'll understand slowly. Some you already understood, but some you'll take some time, okay, as you practice. For example, like I said, here there are 10 questions plus here there are 20 questions. By the time you finish 30 questions, yes, you'll become an expert in anesthesia coding. Believe me. You'll get some doubts, but whenever you have any question, just ask me. Um, yes, yes.